Good morning, dear students. Our lecture today is about bleeding in early pregnancy. At the end of this course, the student will be able to define possible causes of bleeding in early pregnancy, identify the magnitude of the problem in Egypt and its contribution to the MMR, identify symptoms and signs of each etiology for bleeding in early pregnancy, list the investigations for bleeding in early pregnancy, management of ectopic pregnancy, management of molar pregnancy, management of different types of abortion, identify indications and steps of evacuation and curettage, list complications of E&C and their management, causes of bleeding in early pregnancy, abortion, ectopic pregnancy, vesicular mole, local gynecological lesions, e.g. cervical ectopy, polyp, dysplasia, carcinoma, and rupture of varicose vein. By definition, abortion is the termination of pregnancy, resulting in the expulsion of the products of conception of non-viable fetus, i.e. before the 20th completed weeks of gestational age. It is the commonest cause of bleeding during the first 20 weeks of pregnancy. Clinical types of abortion: spontaneous abortion, threatened abortion, inevitable abortion, incomplete abortion, complete abortion, missed abortion, septic abortion, cervical abortion, recurrent, habitual, abortion, induced abortion, therapeutic abortion, elective, voluntary, abortion, threatened type of spontaneous abortion. Although the sac is still healthy, bleeding is coming out of the cervix. The picture shows different types of abortion which will be discussed lately. Spontaneous abortion. Incidence: 15 to 20%. 80% occur in the first 12 weeks of pregnancy. Etiology: causes outside the genital tract. Fetal causes: abnormal karyotype of the fetus, trisomy, 52%, polyploidy, 26%, monosomy X, 15%, blighted ovum, anembryonic pregnancy. Triploidy is one of the chromosomal anomalies seen in abortion, in which the risk for recurrent chromosomal anomaly in subsequent pregnancy is not increased significantly. Spontaneous abortion. Etiology: causes outside the genital tract. Maternal causes: infections, Neisseria gonorrhoeae, chlamydia, Listeria monocytogenes, Treponema pallidum, cytomegalovirus. Any severe maternal infection, bacteremia or viremia, might cause sporadic abortion. Hormonal abnormalities: thyroid dysfunction, progesterone insufficiency. Maternal causes: immunological factors, antiphospholipid antibody syndrome, systemic disease, chronic hypertension, chronic renal disease, trauma, direct trauma, indirect trauma. Causes in the genital tract: cervical incompetence, uterine overdistension, acute polyhydramnios, endometrial polyp and submucous leiomyoma, congenital uterine anomalies, bicornuate, septate, and subseptate uterus, Asherman's syndrome, intrauterine adhesions, third-degree RVF uterus. Induced abortion. Definition: it is the elective intention of termination of pregnancy by artificial means. Indications: therapeutic, medical, abortion. Obstetrical causes: missed abortion, acute polyhydramnios, vesicular mole. Heart diseases: active pulmonary tuberculosis, advanced hypertensive vascular disease, advanced chronic renal diseases, complicated uncontrolled diabetes mellitus, breast carcinoma with pregnancy, severe cases of hyperemesis gravidarum. Elective, voluntary, abortion. It is termination of pregnancy for a non-medical reason at the request of the woman in countries where abortion is legalized. Criminal abortion is that procedures to terminate pregnancy against law. A very nice table comparing different types of abortion. Definition: attempt of the uterus to expel the products of conception. Investigations. U/S intact pregnancy with positive fetal life. Management. Bed rest, sexual rest, mental rest. Progesterone controversial LPD. Prognosis. Threatened abortion may end in term delivery of normal neonate. However, it may end in missed abortion or inevitable abortion. To be discussed in face-to-face lecture. To be discussed in face-to-face lecture. To be discussed in face-to-face lecture. Inevitable abortion. Definition. Complete separation of the fertilized ovum or the placenta from the uterine wall. Spontaneous ROM or uterine contractions associated with progressive cervical dilatation in the second trimester. Management. Blood replacement if needed. Oxytocin infusion contracts the uterus, aids in the expulsion of tissue and limits blood loss. Surgical evacuation. Anti-D if the patient is RHV. To be discussed in face-to-face lecture. Incomplete abortion. Definition. Parts of conception are expelled out and others are still inside the uterus. Retained placenta after expulsion of the fetus in the second trimester. Management. Blood replacement if needed. Oxytocin infusion contracts the uterus, aids in the expulsion of tissue and limits blood loss. Surgical evacuation. Anti-D if the patient is RHV. Complete abortion. Definition. All products of conception have been expelled out spontaneously. Management. If there is doubt about completeness of abortion, D and C should always be accomplished. Missed abortion. Definition. Retention of all products of conception despite embryonic or fetal death. Symptoms. Loss of symptoms of pregnancy. Cessation of fetal movements. Milk secretion. No pain. Plus or minus brownish vaginal discharge. Signs. Uterine size, period of amenorrhea. Fetal heart sounds are absent. The cervix remains firm and closed. To be discussed in face-to-face lecture. Investigations. U/S collapsed gestational sac or absent fetal heart movements. The quantitative beta-HCG may decline. Urine pregnancy tests may become negative within 2 weeks after death of the ovum. In markedly prolonged, greater than 4 weeks, mid-trimester missed abortion, absorption of the products of conception may result in a coagulopathy, most notable for a low plasma fibrinogen. Differential diagnosis. Inaccurate dating of a continuing pregnancy. Management. In the first trimester. Evacuation usually by suction curettage. In the second trimester. Evacuation is most frequently accomplished using prostaglandins. If all other methods failed, abdominal hysterotomy may be needed. If there is evidence of a seriously reduced fibrinogen level is detected, or infection or anemia exists, appropriate therapy must also be instituted. Septic abortion. Definition. Infection on top of any type of abortion. Microbiology. The commonest microorganisms: E. coli, Klebsiella, Proteus, Staphylococcus, Streptococci, especially GBS, bacteroids, Clostridium welchii and Clostridium tetani. The commonest are anaerobic Streptococci and E. coli. Routes of infection: exogenous, endogenous, rarely, hematogenous. Clinical presentation: C/O. Amenorrhea and other symptoms of pregnancy. Plus or minus history of trial of self-induced abortion using AFB. Malodorous offensive discharge from the cervix. Pelvic and lower abdominal pain and suprapubic tenderness. O/E. Tachycardia. Signs of peritonitis. Tenderness with movement of the uterus or cervix. Fever 37.8 to 40.6 degrees Celsius. Presence of hypothermia means that patient has endotoxic shock. Plus or minus jaundice due to hemolysis. Plus or minus oliguria secondary to septicemia. Septic abortion. Complications: immediate renal failure, disseminated intravascular coagulation, pelvic abscess, thrombophlebitis, late Asherman syndrome, peritoneal and tubal adhesions, infertility and chronic pelvic pain. Management: hospitalization, observation, vital signs and fluid chart, resuscitation, large bore intravenous line blood transfusion plus or minus intravenous solution, maintain a urinary flow of at least 30 ml/hour, intravenous antibiotic coverage for aerobic and anaerobic bacteria, evacuation of the uterine cavity D/C. Treatment of complications: abdominal hysterectomy, indications in septic abortion, clostridia, uterine perforation, sepsis that fails to respond adequately to treatment, incomplete response after being in septic shock, recurrent, habitual, abortion. Definition: 3 consecutive spontaneous abortions. Incidence: the risk of 1 spontaneous abortion is 15 to 20%. The risk of 2 consecutive abortions is 2 to 3% of all women. The risk of 3 consecutive abortions is 1% of all women. Etiology: unexplained recurrent abortion, about 50%. Known causative factors: fetal, genetic, causes. Abnormal karyotype of the products of conception. Maternal causes. Anatomical abnormalities of the reproductive tract. Very early, inadequate blood flow to the implantation site. In the second trimester, inadequate accommodation of the uterine cavity. Systemic disease. To be discussed in face-to-face lecture. To be discussed in face-to-face lecture. To be discussed in face-to-face lecture. Hormonal abnormalities. Progesterone deficiency. Uncontrolled diabetes mellitus. Thyroid disorders. Immunological factors. Antiphospholipid antibody syndrome. Chronic renal failure, systemic lupus erythematosus. Infectious cases. Syphilis. Mycoplasma. Listeria monocytogenes. Diagnosis. History. Recurrent abortions within duration of pregnancy, uterine hypoplasia, syphilis. Recurrent abortions within duration of pregnancy, cervical incompetence, Rh isoimmunization. Abortion due to cervical incompetence. Mid-trimester abortion, usually between 16 to 28 weeks of pregnancy. Preceded by spontaneous rupture of membrane. Abortion process takes a short time. Slight pain and bleeding. The expelled foetus shows no abnormalities. The duration of pregnancy is decreasing each time. Plus or minus history of a previous operation as CX dilatation or amputation. Physical examination. General examination. Malnutrition. Anemia. Thyroid disorder. Local examination. Fibroid. Cervical incompetence. Cervical incompetence can be diagnosed by between pregnancies. Passage of Hagar's dilator number 8 without resistance or pain. 2 ml, 6 mm diameter, Foley's balloon catheter can be withdrawn through the cervical canal with minimal resistance. HSG demonstrates cervical funneling. Extensive old cervical lacerations may be detected during pregnancy. The membranes are bulging through the patulous OS. The transverse diameter of the internal OS is more than 2 cm measured by abdominal or vaginal ultrasonography. Investigations. Depends on the suspected cause. Karyotyping both partners and the aborted material. Ultrasound. HSG, hysteroscopy or laparoscopy, uterine defects. Thyroid function tests. Luteal phase serum progesterone levels and late luteal phase endometrial biopsy. Screening for glucose intolerance. ACA, anticardiolipin antibodies.